Yeah, yours. So good afternoon, folks. We're going to get started now. We're just figuring out a few little technical hitches, but that shouldn't stop us from getting going. And there's John. So our technical hitches are well underway. Welcome to the first ever Yaffle Connects. Really happy you guys were able to come out today and enjoy the new space and the new setup for this type of intimate talk and conversation. A few housekeeping items. There's emergency exits all around here. In fact, there's some down here. There's some over there. There's washrooms down this aisle and down this hallway, and you kind of continue around the corner. Please turn off your cell phones or put them on silent. We'll be taking some photos during the session. Let us know if that's an issue, if you don't want to show up in any photos promoting Yaffle Connects or the Harris Center. We're also webcasting this afternoon's session, so just keep that in mind. We certainly don't need mics for amplification around here, but we do need them for anyone listening and watching online. So if you're going to ask a question in the Q&A, make sure you're holding a mic before you start your question, and make sure you introduce yourself so that people online can hear you. Oh, look at that. Okay. So before I introduce today's speaker, I would like to respectfully acknowledge the territory in which we are gathered as the ancestral homelands of the Beothuk, and the island of Newfoundland as the ancestral homelands of the Mi'kmaq and the Beothuk. I would also like to recognize the Inuit of Nunatsiavut and Nunatsiavut, and the Innu of Nitassinan and their ancestors as the original people of Labrador. We strive for respectful relationships with all peoples of this province as we search for collective healing and true reconciliation and honor this beautiful land together. The format for today's session, we have set aside about 25 minutes for our presenter, followed by another 20 to 30 minutes for discussion. For folks watching online, you're welcome to submit your question at any time during the session. Simply email Justin Deering. You can email him at jdeering, DEARING, @mun.ca. And we'll read them out during the session. Today's session is entitled Too Many Pills, Deprescribing for Health. And we have with us Dr. Kathy Balsam from the School of Pharmacy's Medication Therapy Services Clinic. Kathy graduated from MUN's School of Pharmacy in 2011 and started working in community pharmacy. She enrolled in the University of Florida Working Professional PharmD program shortly after and graduated magna cum laude in 2016. She had a variety of different roles in community practice, from relief work to management and pharmacist in charge, and she's continued with her community practice after coming to work for the School of Pharmacy. She was previously the director for the PharmD program for working professionals at Memorial, responsible for the development of the program, and she currently works as a full-time clinical pharmacist at the Medication Therapy Services Clinic. She's passionate about connecting with patients, appropriate medication use, and providing true collaborative practice. Over to you, Kathy.
All right. All right, thank you. I'm really happy to be here. I'm always really excited to talk about taking away medications, which may seem backwards because I studied medications for 9 years, but I certainly believe in the optimization of actual prescription use so that anytime we are using a medication, it's certainly warranted. So, has anyone here heard of the MTS Clinic or the Medication Therapy Services Clinic? A couple of head nods. So we are relatively new. So the School of Pharmacy opened our Medication Therapy Services Clinic in 2015 and really kind of got up and going in 2016. So we see patients based on referral, typically from physicians, but also now self-referral and from any health provider at all. So we see on referral from dietitians, psychologists, anybody. And anybody that's struggling with their medications or just has questions can come and see us. So we actually operate on an appointment basis. So we sit down with patients for an hour to an hour and a half, go through all of their medications, and then afterwards, work with their primary care provider to make sure that the medications that they're taking are best for them. So we recommend changes and do some follow-up there. So we are funded through Munn School of Pharmacy. So the number one question I often get asked by clients is what's the cost? So right now, thankfully, we are able to operate at no charge to the patient. And we are really working to evaluate everything we do at the clinic to show that, what we are doing in this role as pharmacists is certainly worthwhile and showing our worth that way. We hope to generate evidence to inform health policy and health service delivery. So this is, I guess, who we are. So Dr. Debbie Kelly is a faculty member at the School of Pharmacy. She's our clinic director. I'm the full-time pharmacist there. I'm there Tuesday through Friday all day. And then Dr. Amy Clark and Dr. Terry Genge are both faculty members with our school as well, who work there 1 day a week. So who could benefit from coming to the clinic? These are a variety. So anybody who's been in hospital recently, because we know hospitalization is often associated with new medications, changes in medications, new diagnoses, and oftentimes some of the education that's provided in hospital isn't really well remembered when you get home and you transition home and get back to your regular day-to-day. So anybody that's been in hospital recently, anyone who has multiple medical conditions, anyone who takes multiple medications or their regimen is just really complex, anyone that's having trouble with their medications, be it side effects, remembering how to take them properly, etc., and anyone having trouble taking their medications as prescribed. So one of our big clinic programs that's really taken off is our deprescribing program. So we offer a wide variety of services from smoking cessation to side effect management, but one of our big programs is the deprescribing program. So this is where I get to kind of feel like a superhero, because I do find that most of our visits do involve deprescribing and taking away medications, and all of my patients kind of call back afterwards and can't believe that they feel much better without a medication. So it's really, really exciting, and there's been a lot of work done all throughout the country, as well as now, thankfully, provincially, to target the issues surrounding inappropriate medication use. So I wanted to kind of show you what is going on at the clinic. So we've now seen over 300 patients, and this gives you a bit of a snapshot of who we're seeing. So the average age of our clients are around 69 years old, but that certainly ranges. The majority are female. The average number of medications before the visit is 11, but it does range. On average, we identify 4 drug-related problems per patient, and 56% of our assessments actually involve some sort of a deprescribing recommendation. So that is certainly the majority. And the little pie graph there shows you that 25% of the problems that we identify is actually related to no indication for the drug, which means there's no real reason that person needs that medication anymore, which can be somewhat shocking. But sometimes when medications are started, they're for short-term for symptoms that should only be there for a short term, and they're often continued on much longer than originally anticipated. Sometimes, they just get written over and over again without being properly evaluated. So we certainly identify a lot of those problems. Another big section there is the light blue section at 10.4% is the category that is involved with too high of a dose. So in that case, the medication is actually indicated, but the dose is too high, and we can actually just drop the dose. And I will get you to focus there again on the light green. So that is 7.3% is more appropriate drugs exist, which means maybe there was a medication that was causing side effects, and now we know there's a more kind of better and improved medication for that same condition that we could switch them to that would be safer. So certainly, we are certainly seeing a lot of people that are on medications that they may no longer need or may no longer need at those high doses. It is also important to note that 17.4 there, that's actually indication for a new drug therapy. So there are also, we don't just do deprescribing, we do also identify people that do need a medication for therapy as well. So what is deprescribing? Does anybody have an idea of what I mean when I say deprescribing? Yeah, so stopping medications. So most people think it's stopping medications and that's all it is, but it's also decreasing the dose of a medication, and the term also includes switching to a safer medication. So anytime that we're switching medications to decrease them or take them away and make things safer. So there's a Canadian deprescribing network that started a couple years ago, and thankfully their growth has just been exponential. So it started with just a couple geriatricians that were really interested in, is there a way that we can do something about our high medication use in our seniors? And it's just started to grow and grow and grow. So this network involves patients, healthcare providers, caregivers, policymakers, anybody who's interested in this topic can certainly get involved. And we meet, there's conferences every year, and they are constantly coming out with new guidelines, new patient brochures, things to really help with decision making in that regard. So they define deprescribing as the planned process of reducing or stopping medications that may no longer be of benefit or may be causing harm. And the goal is to reduce medication burden while improving quality of life. So some people get concerned when I start talking about taking away medications because they think that something bad is going to happen or they'll be worse off. But oftentimes we're doing this based on evidence-based guidelines and really can communicate with the patient that we really do think that this is in their best interest. But the biggest message should also be that medication should not be stopped without first consulting your doctor or your healthcare professional, and that deprescribing should be done in partnership to determine what's the best way. Some medications can't just be stopped cold turkey. That would be very uncomfortable, so some certainly have a planned process that we need to follow. So it is important to kind of work together. So anytime that I meet a patient and I really think that there's medications that could be deprescribed, I call their physician and see if there's anything that I'm missing, and then have that conversation with the prescriber to see if they're on board as well. So why deprescribe? I think some of this is pretty clear. So taking medications may be obviously necessary for health, improving symptoms, or prolonging life expectancy. But as we get older, the benefits and risks of medications change. So something that might have been great for you when you were younger, all of a sudden, as we get older and our organs change, our function changes, those medications may no longer be a good idea. So that sometimes it can just be a function of time. So the risk of harmful medications and hospitalizations increases when you take multiple prescription medications. And obviously, as we get older and we may get more medical conditions, we often get multiple medications added on. And as we start stacking them, there can certainly be interactions. Older women are typically more susceptible to adverse effects of medications, and they're more likely to be prescribed risky medications. And when surveyed, 71% of Canadian seniors actually said they were willing to stop a medication if their doctor said it was possible. So certainly our seniors are on board with this. This is just an example of a quote that we had recently from someone that saw me at clinic. So he said, "I always felt I was taking too many pills. My doctor mentioned that I could go to the MTS clinic and meet with a pharmacist to discuss my medications. My wife called, booked me in, and I'm so glad she did. I was overjoyed with the service. I learned a lot, and now he's working with my family doctor to help me come off of 3 medications, and she switched my diabetes one to a safer one." So this is kind of an example of a case that we've seen in clinic. So I want to bring up a case so that we can kind of come back to this as I'm talking through things. So this is Lucy. So Lucy says, "Do I really need all of these medications?" So when we look at her drug list, this is it. So she's on quite a lot, a little bit more than average, but not uncommon. So she's got clonazepam for anxiety, donepezil for her memory, rabeprazole for her stomach, metoprolol and ramipril for her blood pressure, glyburide and metformin for diabetes, loperamide, Imodium for diarrhea, naproxen for arthritis, oxybutynin for her bladder, iron pills, a stool softener, a cholesterol pill, and aspirin. So this is quite common of patients that I would see in clinic. So what can we do for Lucy? And does she actually need all of these? So we'll come back to her. So I guess just a little bit of a quiz or to see if you guys are familiar with some of the stats. When it comes to seniors and their use of medications, how many seniors over the age of 65, or as a fraction, do you think are taking over 5 medications? Do you think it's 1 in 5, 1 in 10? 4 in 5? So 2 out of 3 Canadians over the age of 65 take at least 5. So then if we look at how many are taking at least 10, would you say, 3 out of 5, 2 out of 5, 3 out of 5? So 1 out of 4. So a quarter of our seniors over the age of 65 are taking at least 10 medications. So you can certainly see there's, certainly a high use of prescription medications. So when we look at seniors taking more than 10, 66 are taking over 5% or over 5 different medications. And it does say 1 out of 4 Canadians over the age of 65, but that actually increases as we age. So it's 20%, 65 to 74, and it goes up to 39%. So the Canadian Deprescribing Network really wanted to look at all of the different provinces and see what's the scope across the country. Is it the same in every province? What's different in terms of policy in different provinces? Where do we land? So they've targeted some particular drug classes that we're concerned about or that we can start with. So instead of just saying look at all medications, they've targeted to certain classes. So the first class they look at in the red is PPIs. So these are stomach medications. So your Perrier, your Losec, your Nexium, those sorts of medications, highly used. And they are proton pump inhibitors. So they stop your stomach from producing too much acid. And when you decrease the acid, you don't get as much heartburn. So it's pretty simple, but there are long-term side effects associated with them. You need acid in your stomach in order to break down your food and in order to get the nutrients out of your food. So some people, if they take them for long-term, they can get low magnesium, low B12, those sorts of things. We also need some acid in our stomach to break down some of the drugs that we take. So some of our drugs don't actually work as well if we have these medications on board. So when you're talking to a senior that may have 10 or more medications, if they're taking these, that can interfere with other medications that they're taking. And if you look at Newfoundland, sorry, it's in the orange. So we're at 29%. So a third of our seniors over the age of 65 are taking these medications regularly. And this is not just when they have heartburn, they take one. This is every single day. So if we look at BC, their rate is only 8%. So I don't think Newfoundlanders have that much more heartburn. I just think that we treat it differently. So we have a tendency to use these medications and use them really broadly and regularly. In BC, the provincial drug card stopped covering them. They covered a safer agent instead. So they use a different agent that's a little safer. So certainly things that we can do, but in the coming months, you're going to be seeing some work out of our provincial group called Safer Meds NL, which I'll touch on in the end. But they're starting with PPIs and encouraging patients, if they're taking them, to talk to their doctor or their pharmacist. The other one there is opioids, and I don't think I really need to talk too much about the opioid crisis. But I think a lot of people in Newfoundland don't think that we're using a lot of opioids. But I think it is important to note that we are the highest use of opioids as well. Sometimes we just think of, downtown Vancouver being a problem area, and we are not, but I don't think that's fair to think. We certainly have a high use here as well. So when we look at the next drug class, so benzodiazepines, these are your Ativan, your diazepam, those sedative hypnotics. So they're certainly used and certainly validated to be used in certain conditions, but people that are using them for sleep long term is not a good idea. Increases the risk of falls, impairs your brain functioning, all sorts of things. And when we look at our seniors, 21% of our seniors are using these regularly. I come from a community pharmacy background, and I have spent days filling prescriptions for Ativan for seniors and clonazepam for seniors. And for anxiety, it can certainly be warranted, but when it's being used for sleep, it's not. So we can do a lot when it comes to education to different healthcare providers, to patients. We do a lot of work with encouraging patients to use mindfulness and cognitive behavioral therapy for sleep that's much safer than using medications. So what drugs do we target? I mentioned most of this. So benzodiazepines, they can cause memory and concentration problems, falls and fractures, etc. The proton pump inhibitors over time, where they can decrease your magnesium and things, they can cause hip fractures. Anyone on a PPI also has higher risk of pneumonia. Higher risk of Clostridium difficile infection, that's a gut infection. Glyburide is also commonly used in Newfoundland. It's an old diabetes medication that causes a lot of dramatic low blood sugar incidences where people can have falls and that sort of thing. And that is another drug that the Canadian Deprescribing Network is targeting. So I want to talk about prescribing cascades. So I think a lot of people are familiar with this idea that you get started on a medication that causes a side effect. Instead of changing the medication that causes a side effect, you add on another medication, right? So this says, well, the white pill lowers my blood pressure but causes my legs to swell. The yellow pill lowers the swelling but causes me to pee, et cetera, et cetera, et cetera. So you can see where this certainly happen. So I want to think back to Lucy, and this could have certainly been a prescribing cascade that landed her with those 15 medications. So let's say the first thing that she experiences is arthritis. So she ends up on naproxen, which is Aleve, but most people that have arthritis take a high dose of that for the inflammation and the pain. So if you take anaprox, it can cause hypertension. So it causes her blood pressure to go up, so she gets put on a blood pressure pill, and that's a combination pill of two different medications in one. So part of that medication is the hydrochlorothiazide. That's a diuretic. It makes you pee more, and that's how it works to decrease your blood pressure. But you give a senior something that makes them pee more, it can cause overactive bladder. So then she ends up on oxybutynin, which is a medication for her bladder. So over time, if you take anaprox, you can end up with really bad stomach and heartburn. So she ends up on rabeprazole for her stomach. And we know that these PPIs can decrease the amount of iron that we get absorbed from our food. So she ends up with iron deficiency then. And so she gets on an iron pill. Iron pills commonly cause constipation, so then they add in the stool softener docusate. Over time, oxybutynin for overactive bladder can actually mimic dementia. It can cause cognitive impairment. So she ends up on a medication for her memory. And oxybutynin can also exacerbate constipation, so her constipation gets worse. So then she gets diagnosed with diabetes, and she ends up on glyburide. It causes hypoglycemia or low blood sugar. She gets dizzy and falls down, but that could have also been a result of the oxybutynin. So you can kind of see how everything is kind of intertwined. And if we made appropriate choices at various steps here and perhaps even changed out certain medications, we wouldn't end up with that cascade. So we really work to see if there's any parts of this cascade that we can change and then maybe take away multiple things down the line. So of course, one of the biggest things with medications too is that they can cause falls, which of course can land you with a hip fracture and hospitalization. And a lot of seniors that have hip fractures don't end up back in their own home. So what does this cost? So Canadians spend about $419 million per year on potentially inappropriate medications. That's about $75 per senior. And I actually think it might be higher than this, and I'll explain why. And Canadians spend $1.4 billion per year to treat the harmful effects of these inappropriate medications. So we're really trying to stop the use of these inappropriate medications so that we don't have to spend that money down the line. So where they came up with that $75 per senior is they did this study here, the frequency and cost of potentially inappropriate prescribing. So what they actually did is they looked at the electronic health databases, and they had a list of medications that could be considered inappropriate in the elderly, and then looked at their electronic health record to see how many of their seniors are taking those medications. And that's where they came with the $75. But I will tell you, things like blood pressure medications aren't on that list, but they can be inappropriate in patients that don't need the blood pressure pills anymore and their blood pressure is low, et cetera. So I actually think it may be a little bit higher than 75, but this is one of the first studies where we get a dollar value to put on that. So when we look at seniors, we know that they're at more of a risk of getting prescribed a potentially inappropriate medication. So what fraction of drugs commonly used in older people could be considered inappropriate? Do you think it's 1 in their list of 10 could be considered inappropriate? Do you think it could be 1 in 5? So 1 in 5 drugs commonly used in older people may be inappropriate. And I mentioned earlier that females seem to be more at risk of getting prescribed an inappropriate medication. They're not really sure why that is, but some of the hypotheses is that women actually seek medical attention more. So that just seeing a physician or a prescriber more often may land you with more medications. And also hormonal changes, we are more susceptible to certain conditions that would require medications as well. So I wanted to touch on one example of our research that some of the seniors are really interested in when I get to talk about this. So we went to St. Pat's Mercy Home. Most of us are probably familiar with that home. So CIHI, or the Canadian Institute for Health Information, gives a lot of all of the nursing homes across the country a bit of a report card on how they're doing and various things. And one of the things that they look at is prescription drug use. So, and it's not just St. Pat's, it's homes all across our province have actually shown that we use a lot more medications than the national average in our long-term care facilities. So St. Pat's is kind of like our neighbor. We are just off Elizabeth Avenue is where our clinic is located. So they asked if we could do something and help them out. So they wanted our pharmacists to go in and evaluate their residents, have a look at their medication list, and see if we could take away any medications. So we did it as a randomized control trial to evaluate the evidence for it. And we started with just one floor. And when we went in, we took one unit of the residents, randomized them, and when we looked at their medication list, we actually took away on average 2.5 medications at the 3-month mark, and then you can see that even grew to 2.78 on average that were taken away at 6 months. So we worked with the doctors that work there and the nursing staff and everything to come up with other ways to treat some of the things that they were commonly using medications to treat. And thankfully, nothing bad happened. So I guess the biggest thing that we were concerned about is that we may cause harm. And all of the research out there says that there's no real harms associated with deprescribing if it's evidence-based. And of course, no impact was found on cognitive function or survival in this study. And when we look at the seniors that we took away medications on, the majority of the medications that we took away were supplements, which seem a bit benign, but some supplements are not. So when someone gets admitted to long-term care, they automatically get put on calcium, which seems like it's okay because we want to make sure that we're not increasing our risk for fractures, and we know that calcium can decrease the risk of fractures if we fall. But a lot of the residents on this unit at St. Pat's were actually bedridden, and they were never going to kind of be up and moving around on their own, so really didn't have that same risk of having a hip fracture. And a lot of the calcium products, especially in the elderly, can cause some serious constipation, can even lead to bowel impactions and hospitalizations that way. So you can see down in one of the other ones, one of the blue ones says the bowel preps. So oftentimes we were able to stop the calcium supplements, which allowed us to stop their stool softeners and their laxatives. So you can kind of see some deprescribing cascades as well. The next class there is antihypertensives. So those are medications used for blood pressure. And rightfully so, they don't often check blood pressure of the residents in long-term care because they don't want them to feel picked and prodded at. This is their home. So they only do it if they see that it's necessary. But as part of our assessment of whether or not they needed their blood pressure pills, we did check their blood pressure. And a lot of the residents that were complaining of fatigue, dizziness, had fallen even, their blood pressures were really low. So medications that they may have needed when they were younger and they just kind of got continued on over time actually could have been decreased or taken away in terms of their blood pressure and allowed them to still have blood pressure control. PPIs there, you can see there's pain medications, certainly a variety of medications that were able to be deprescribed there. So we really wanted to go back and talk to those that were involved in the deprescribing process to see kind of what are their thoughts about it. So we had a summer student start with us, and she interviewed the physicians, nurses, the pharmacists, and some of the students about this. And she came up with kind of 4 common themes that were seen throughout all of the interviews. And one of them was that education is really important to decrease the barriers when it comes to deprescribing. So patient education, so when you tell the patients about why you're thinking about stopping their medication, it certainly increases their willingness if you really bring them in and educate them. Health professionals, when they know more about that specific drug and just kind of get reminded of reasons why we wouldn't want to use it long term, it really helps. And education just in general. So we actually sat down with all of the teams ahead of time and gave them some education about different things. For example, the Ativan. A lot of times if a patient was agitated, they would give Ativan. And now, a simple thing, and I don't know if the dietitians love it, but they actually just started giving them a bowl of cheesies. And it worked wonders. So it was enough to allow them to feel cared for and, just distracted. And it was wonderful. That bowl of cheesies just as much as that Ativan without increasing the risk of falls. Actually, the nursing staff did. Yep, they had all kinds of things. They've actually got like a robotic cat as well for pet therapy. They got all kinds of things that they've implemented. Yeah, their cheesy budget is going through the roof, but their drug budget is being saved. So one particular quote is there is more openness to deprescribing now since the study started because there has been that extra education with the staff. So when you spend that time kind of upfront, allowing them to know that they have that support and to be educated really makes a difference. The lack of information presents a challenge, and this is always, no matter what, where in healthcare you are. I found that this is certainly a challenge. So patient history is often hard to find. I mean, if we're dealing with people that are traditionally in their 80s plus, it's hard to know, did they have a heart attack in their 30s or 40s? And the patient record is often not there. You can't find it. And that information certainly presents a challenge. So sometimes we don't really know why medications were started, and we're trying to make our best guess, but we're doing so with as much evidence as we can. Oftentimes as well, some family physicians are apprehensive about changing a medication that was started by a specialist, rightfully so. And sometimes we don't have all the information about why the specialist chose that medication, etc. So one physician said, I was hesitant to recommend stopping something prescribed by a specialist, and I think the resident was as well. So that can present a challenge. So the lack of information is certainly an issue. Everybody agreed that medications are being overused. Often medications that are no longer necessary are never stopped. Sometimes people think that if it's not broke, don't fix it, in the sense that, if they're on medications for years, nothing bad's happened yet. But we don't like to think that way. We like to be proactive about things. and they've recognized the prescribing cascade as well. So the biggest concern is polypharmacy. Everybody gets started on medications, but they don't get stopped. And the last one is that coordinated healthcare is important. Patient and family inclusion, including everybody on the team. The lack of time amongst the nurses, physicians, and the pharmacists was a big thing. We were lucky enough to have a lot of pharmacy students that were just finishing up their program be involved in doing actually a lot of this assessment. So unfortunately, the pharmacist that works at this long-term care facility works at a whole bunch of other ones and also in a dispensary too. So her time at the home is limited. So this isn't available to everybody, and not the way it is right now. It's not able to be scaled up. But we were able to get in and do this because we had the pharmacy students. So we're hoping to increase the amount of pharmacist time that's spent in long-term care. And having a designated team member to actually look for opportunities to deprescribe makes a difference. Once you give somebody that ownership of the project, it's certainly more effective. We asked them what are the main risks to residents taking a large number of medications, and the number one thing said by all of the healthcare providers was the falls. And falls can be very, very, very detrimental. They can certainly impede on quality of life. And a lot of people that have a fall, particularly if they get a hip fracture, they don't end up having nearly the same amount of quality of life as they had before. So then we had another student go in and talk to the residents. So I thought this was wonderful. So when we asked the residents how they felt about it, one of them said, sometimes I wonder why I do take these medications. It's a lot, but I'm alive. Thankfully, one of them said, I think any pills that I've gotten from the doctor here have been explained to me. Some of the residents said that they don't really know what they're taking, but that particular resident said that it had been explained to them. One gentleman said, I don't question my medications. I don't know what they are. You do. So I don't see why I should. I got enough faith in you that you're going to give me the right medication. So that was nice that they had faith, but I do want the patients to feel involved. At one point we said, what do you see as your role in the decision-making process? They said to pay for it. So that was a bit discouraging. And who do you think should be involved in decisions regarding your medications? And they said the doctor and the pharmacist. Do you think you had a side effect because of a medication? Oh yes, I felt dizzy and I fell a couple of times, sure. So it's certainly interesting. We've got pages and pages of results that way. And then we spoke to family members. So some of these were key as well. So one of them said, at the end of the day, it's got to make sense why they're on it and the impact that it's having on your loved one. So they want to know what the impact of them being on it versus them being off of it and having that shared decision making. So they said we would certainly look for the advice of the doctors or the pharmacists to look at the impact of coming off and what that would mean. I think that families should know what their loved ones are taking, and if there's a change in medication, it's important to advise them of that. They did agree that it should be a team approach. I think absolutely a pharmacist is essential because they have that drug knowledge. The nurse is there on a regular basis and really knows that patient, so that's super important. And the decision certainly cannot be made in isolation, and the decision that would be appreciated would be the one that is a team-based approach. So on a national basis, I talked about the Canadian Deprescribing Network a little bit already, so just about them as well a little bit more. So their goal is to reduce harm by raising awareness and cutting risky prescriptions for seniors by 50% by 2020. So a big goal, but they're going for it. We'll see. They're doing a lot of work to evaluate different programs that they've been doing across the country. I myself am constantly out talking to seniors groups and telling them about this sort of thing. And it usually stimulates them to come in and have a chat and come to the clinic and be assessed on an individual basis. So they're certainly working to promote health by ensuring access to safer drug and non-drug therapies as well. So provincially, we have our Safer Meds NL. So there's a pharmacist that works at our office that's associated with them. And it's certainly worth checking out their website. They've got a lot of really good decision-making tools for clinicians, but also patient information that you can kind of look on and say, how do I get a good night's sleep without my sleeping pill? Or how do I go through my day without heartburn if I'm not going to take my stomach pill? Different things to help them through it. So certainly worth looking into as well. They're going to be doing a lot of public promotion coming up, and there's a big project now regarding the proton pump inhibitors or those stomach medications where the pharmacists and the prescribers are going to be working together and really looking at people that come and present to the pharmacy with a prescription for a PPI. The pharmacist is going to kind of talk to them a little bit more about it and then suggest to the physician that they may be able to be changed. So there's lots of resources. Deprescribing.org has come up with algorithms for clinicians to actually follow through and determine if the medication can be deprescribed. The Canadian Deprescribing Network, like I mentioned, and MEDSTOPPER. MEDSTOPPER is commonly used for clinicians where we kind of just input all of the medications a patient is on, and then it gives us these happy faces or sad faces, depending on if we should get rid of it or not and why. But patients can certainly have a look there as well and put in their medications and then use that, bring that kind of report to their pharmacist or their physician and have that discussion with them. These are an example of the deprescribing algorithms that we use as clinicians. So why is a patient taking a benzo like Ativan? And then we go down through it. And it tells you when you would continue it, because there are certainly valid reasons to do so, or when you'd recommend deprescribing it, and then how to do it. Because this is an example of a medication that cannot just be stopped cold turkey. You can have significant withdrawal. So you do want to decrease the dose slowly. So if we go back to Lucy, the first thing we do is we talk to her about her clonazepam. So she was actually using it for the sedative property. She wasn't using it for the anxiety. So they worked with her, tapered that off, and that was able to go. She felt a lot more awake and that sort of thing. The next one, so they switched the Anaprox over to Tylenol. So for arthritis, our Tylenol arthritis sometimes works just as good as the anti-inflammatories. It doesn't cause stomach upset and doesn't cause high blood pressure. Because she doesn't have that medication that causes high blood pressure, we can get rid of one of them, but it doesn't cause the reflux either. So we can get rid of the reflux medication. Glyburide is that really bad diabetes pill that we don't like people to use, so they switched it over to a safer one. People that are on iron replacement often don't need it lifelong, depending on their diet and different things. So she had been on iron for many, many years, and her iron stores were certainly replenished, so we can get rid of that, which means then we can get rid of our stool softener. We can change up her medications for her blood pressure and get rid of the one that was causing her to go to the bathroom all the time. So then we were able to get rid of the bladder medication. And because she's not on that bladder medication that caused cognitive dysfunction, her memory's back. So she doesn't need that memory pill either. And now Lucy is really happy. So most of the time, you know, this is an example and a little bit of an extreme example in the sense that there's multiple things. But in most cases, we're able to deprescribe a couple things. So we look forward to helping your patients with their medication therapy needs, or maybe yourself or anyone that you care for, or anybody that you're involved in. You can certainly contact us at any time. We have a website. There's referral forms on there if you're a healthcare provider, and also if you just want a self-referral. We've kind of taken away all barriers. Patients can just call themselves and say, I want to come talk to someone. So, you know, no barriers that way, and we'd be happy to see anybody. Right now we have about a 2-week wait list, but it's certainly not long at all. So any questions? Okay. Yes.
Hi. First of all, thank you very much. I get all that information. Superwoman, super fits, right? How about the supplement section? We're in the pharmacy and it's grown exponentially.
Mm-hmm.
And my covered circle, not me,
Yeah.
I won't even go to work, but full of supplements. And perhaps there almost seems to be a focus on that because there's any number. So do you have any comments on that?
Yeah, so we certainly encourage everyone that comes to the clinic to bring all of their medications, and we specifically say including vitamins, supplements, herbals, and all that sort of thing. So, I mean, there has been certainly an explosion of these products, and for a lot of things a lot of medications that are supplements and available over the counter can be perfectly safe, but when you are combining them with other medications, they can be really bad. We had a patient this morning that was taking magnesium and didn't think much of it. But one of her other medications has a potential of increasing her magnesium level. And then she was taking magnesium on the side because she read online that her leg cramps may be caused by low magnesium. And having too much magnesium can cause arrhythmia, like your heart rhythm to go off. So it's very important to, if you are considering these medications, ask your doctor, ask your pharmacist. Thankfully, now in Newfoundland, we have the electronic health record. So if you've gotten blood work done in the last little while, you can ask your pharmacist to check and just see if they've had a magnesium level done and maybe they can gauge. You know, if it's already high, we certainly don't want to be taking magnesium off the counter. Absolutely. So we tell people bring in absolutely everything, and we make a point to say including vitamins, herbal supplements, because they do certainly play a part in all of this.
pharmaceutical industry
Yep.
who make all this money.
Mhm.
I know you've made references to relationships with doctors,
Yep.
but the representative associations and the pharmaceutical industry, for example, your funding internally, you say it's not costing anything. Is the pharmaceutical industry funding what you're doing? And do you have a relationship either nationally or provincially with the pharmaceutical companies?
No. So I am the full-time pharmacist. The other pharmacists that are at the clinic are faculty members. So this is just kind of a clinical job for them in addition to their teaching responsibilities. So I'm paid for by the university, fully by the university, nothing else. Like we are not getting any grants or any supplemental money from any pharmaceutical company in any sense. I guess the only thing, I go to all of these continuing education events that physicians will put off when they're learning about new drugs that come to market, which are of course funded by pharmaceutical companies, but there's a lot of work done to make sure that the biases are taken away as much as possible in order for these things to get accredited by our professional organizations. So I really don't think that there's any influence in that sense. And I don't know how much they would love us because I do take away medications more often than not. So I don't know if they would feel comfortable giving us funding. But there's certainly no financial background or money changing hand that's coming from industry there. Yes.
This is very senior focused, but I have a reference in my mind about children.
Yes.
Children who are obviously medicated, and that wasn't a part of this discussion
No.
whatsoever. So just curious about that.
Yeah, so I certainly do see younger folks as well. The youngest I saw was 13. So of course, then they come in with their family or their parent or guardian. And oftentimes in those cases, it was mental health struggles that they were going through, and then they were having some side effects from the medication. So that can all be part of it as well. In that case, we're usually recommending different medications and sometimes deprescribing different things, certainly encompassing everybody. I'm just realizing there as well, because I did have a slide there about the clinic and how our average age is a certain range. And then there was a range, and I think it said 51 to 80, but that must have just been a snapshot that one of our folks doing the evaluation looked at, because I've seen people in the teens as well. So that's not all encompassing. That was just kind of one snapshot of people that we had seen. Yes.
For example, a list of medication that Lucy was on, they were prescribed by a physician.
Yeah.
They were dispensed by a pharmacist.
Yeah.
And then they come to your clinic so you can undo all that. Is there a way to maybe provide more education to the prescribers to begin with?
Yeah. And we're certainly working on that. I think there are a lot of factors, and some of it came up in the qualitative analysis that I think would also carry forward to kind of community dwelling folks, not just our long-term care folks. But when it comes to the patients, they say, my doctor gave me this, and, are they going to be okay with you telling them to tell me to stop it? But oftentimes the physicians have come back and said, I've always wanted a chance to go through this, but I don't have the time, So everybody's pretty good at buying in and working together. I think the Provincial Safer Meds NL is doing a lot of work with physicians and prescribers and nurse practitioners and all that sort of thing to try to nip it in the beginning, or have them evaluate when people are coming for refills to start to think if you need these. And I will say the physicians that actually work at St. Pat's only work there a couple hours a week, and they have full family practices on the side. They just go in there and take care of their residents a couple hours a week. And they've said that since they've done this and really focused on it and did some more education, they're doing a lot more deprescribing in their own family medicine practice as well. So I'm hoping it's going to be a little bit of a domino and a trickling effect. It's going to take a while to get there because some of these prescribing patterns are ingrained, And from a community pharmacist, as a pharmacist, I didn't feel biased, but you are ran by prescription value, right? So the whole reason why community pharmacies are running is because they get the dispensing fee. That's the only way that they get money these days. So unless we start really reimbursing them for cognitive services so that they can get reimbursed for actually looking at a patient's medication list and saying, wow, I don't think you need these, let me talk to your doctor, and taking that time to go through that and have that conversation, if we can get the community pharmacists reimbursed for that, it may not be so difficult to grow on this in that regard, because they're so ran by prescription volume otherwise as a business model. And that's not the actual individual pharmacist. It's often coming from head office and pharmacy management. but we've got to find a way to change the way that pharmacists are reimbursed and what their actual kind of day-to-day involves. Yes.
Is there any sort of organized referral system in place for, there are a lot of drugs people are on that they could be off of if they change their lifestyles a little? So, and that's also stuff that gets missed in a short GP visit.
Absolutely. So we do kind of, before we even dive into the medications, we talk about lifestyle factors, so smoking. And as a pharmacist, I certainly don't know everything there is to know about diet, but I do know certain things. So I'll provide a little bit of advice, but anybody that needs help in terms of their diabetes control or their blood pressure control, and a lot of that could be managed by changing their lifestyle and their diet, I refer to dietitians. So I send a lot to the diabetes educators, and otherwise I'm sending them to the grocery store dietitians, and people that I've worked with that I know that have a wealth of knowledge in that world that I think is being underused. So we're sending them that way whenever we can. Okay.
From antibiotics. I'm wondering if the MTS clinic is outside St. John's area.
Yeah, so great question. We are able to offer our service via FaceTime. So we have an iPad, and as long as you have an Apple device that has FaceTime, we are happy to do that. I've seen people in Port aux Basques and the Northern Peninsula, all kinds of all over the province. So certainly that way. We unfortunately don't have access to the Eastern Health telehealth services because of the funding. We would have to pay to use that, and it's a little bit of a pretty penny. So we're working on that and working at different ways to reach people, understanding that not everybody has an Apple device. We can use Skype and those sorts of things if the patients are okay with the potential for that to be unsecure. So by all means, if you're interested and you're not in St. John's, you can certainly call us and we can figure out a way to deliver it. We prefer not to do it on the phone because then we can't really determine how well things are understood, and it can be a bit distracting to just be on the phone. So we do like to have that face-to-face, even if it's by electronic means. Yes.
A list of medication and you suggest other medication, do you take cost into account?
Absolutely. So the first question that we ask is your drug coverage. So unfortunately, we know that that is often a big limitation in terms of what we can add, what's covered, what's feasible. So we always ask. And I think my background in community pharmacy helps that way, because I think that was the major thing that I dealt with on a day-to-day is insurances and coverage as a community pharmacist. So I'm pretty familiar if someone says they're a Great West Life, or I have a teacher's plan, or I work for federal government, I kind of already know what things are covered and what isn't. But if we are recommending any changes of medications, particularly ones that we know are really burdensome cost-wise, we're taking costs into consideration. Yes.
That was really insightful. Excuse me. One of the things I was wondering, and maybe that doesn't really steer group or to this study in particular. Could you comment on the role of antibiotics in prescribing medications? Because I know there's a lot of talk that we overuse them, that we use them the wrong way. There's accumulation and resistances in the environment. Is that something?
So we do look at it. I think thankfully the majority of people that I've seen aren't on long-term antibiotics. So that's a good thing. I don't know if somebody's already got to them before I get to them or whatnot, but the majority of people I see aren't on long-term antibiotics. We do talk to patients, people, for example, with COPD, and they have, underlying lung conditions that put them at risk for infections. They often have standing prescriptions for antibiotics. They may not be on it when they come to see me, but I see it there, and they may pick it up occasionally, and we'll have that conversation about, when do you use that? And when you do use it, do you make sure you tell your physician that you used it, and then you have that conversation about was it appropriate or not. So we do have that little bit that way. I find sometimes we get elderly women in particular that are on long-term antibiotics for urinary tract infection prophylaxis. And sometimes that's warranted because they've had some pretty severe urinary tract infections that landed them with delirium and in the hospital and that sort of thing. But we have also recommended deprescribing antibiotics of patients in that same sense that don't have the same risk that really warrants the long-term use. So not a big part of what we do, but certainly included in what we do. Yes.
Surveys that show that in some cases, for example, for mood disorder or other conditions, that people are on medication, but the dosage isn't appropriate, and it's not effective at all unless the dosage is appropriate. Have you experienced that? And
Yeah. So we often see, sometimes we'll see patients that are on doses that are too low. And then sometimes, of course, we see people that have doses that are too high. So we're always wondering, anytime that, in particular, if someone has a mental health illness or mental illness, we'll talk about, how are your symptoms right now? Do you feel like they're controlled? Has your dose changed? Was it better before? Is it worse now? Kind of really assessing whether or not that dose is working for them. And then we'll always go back to the prescriber. Interestingly, we've had a couple of psychiatrists that are referring to us pretty regularly, which is a really nice thing to see, because of course they're certainly drug experts in that field as well, but they're always looking to see, they recognize that they're prescribing a lot and the patient is on a whole bunch of other things for their heart and their diabetes, and what is crossing over there. A lot of antipsychotics, for example, can cause metabolic disturbances and drive your sugars and your cholesterol through the roof. So then they want to make sure that everything that they may be causing from those medications is handled by other.
So nobody else has one here. And we also had a request online to summarize the questions to go with
okay.
that on the locale. I guess that sometimes the sound is hard to hear.
Okay.
But I keep hearing or heard from the presentation, the use of electronics, record keeping, access to information, but also like almost like a hands-off approach from the patient's perspective when it comes to their own medication management. And I wonder how much of that is changing now with more access to information and also electronic record keeping. Has that been your experience that it's that younger patients are coming in with a bit more knowledge of things, or is it also?
Yeah, it certainly is, because I mean, you can get two different camps of people. You can get, if my doctor tells me to take it, I'm not asking any questions, I'm just going to take it. And then you've got them that, my doctor told me to take that, but I'm not actually taking it because I read online that, so then you can at least dispel some myths, really help them decide whether or not they should take it or not, or whether they or not they should go back to their physician. So interesting. I mean, we had a husband and wife this morning in their 70s that were very aware and had a lot of very valid questions, and we're even referencing studies on cognitive behavioral therapy. An example of a patient that was on Ativan and felt like she couldn't sleep without it, knowing that she had to get off of it. What is a risk of a fall? And really, really well educated and really well in tuned and wanting to be a part of the decision-making process. So thankfully, it's not just, our young people that are reading a lot and being fully aware and asking questions. It can be any age range. People are certainly getting more aware. I find that when you do look up things on the internet, you've got to take that with a grain of salt, and we're still really trying to pump that idea into people, because it can be really frightening out there sometimes, and that's completely unwarranted. I also find, in terms of access to information, as a pharmacist in the community, for example, now we have access to your electronic health record. So before, if I was filling a prescription for an antibiotic and an interaction came up that said, this could actually cause an arrhythmia in this patient, I knew nothing about the patients. I knew nothing about the lab work. I knew nothing about their heart function. I had no access to any of that information. So then I had to call a physician, and oftentimes you're waiting on hold for a very long time, and sometimes you're told, you can't talk to them, just fax over your explanation. So then you're there and you're on fax, which seems archaic, but we still use it all the time. And we're faxing over to the physician, and the patient is upset because they just think that they should get their antibiotic, but you don't want to cause a heart problem, but you don't even really know if you should be worried about it or not because you have no information. Now, I can log on if the patient, I can say, do you mind if I log into your electronic health record? I want to see what's going on with your heart function because there could be an issue here. You look on, you say that they had an EKG done in their QT interval that could be affected by the medication is perfectly fine and really low. So you already have an idea, okay, maybe the risk is actually kind of low. But then you can also think, okay, what is this infection treating? And is there a safer medication that we could use anyway? So then I can actually pull up their, say it's a urinary tract infection. I can look at their urinalysis and say, okay, they were also actually, this organism that they're growing is susceptible to another different antibiotic that won't even affect the heart at all. So instead of calling the physician before and asking them, well, what do you want me to do? What is the risk? That physician on the phone may not actually know at that time, what that patient's heart function is, what other antibiotics would be suitable, and then they don't have the time to deal with that. But at least now I can call and be much more efficient and say, we have this risk of potentially increasing or affecting her heart rhythm. She's also susceptible to clindamycin. So can we use that instead? And usually that helps. The physicians are much more grateful because you're actually providing them with a solution, and they don't have to go back and do all that work. So the access to information has changed my practice exponentially. I would not be able to work at this clinic if I didn't have access to an electronic health record. It would be pointless because I would not have that history. I wouldn't have access to the lab values. I wouldn't have all of that. So without the electronic health record, this clinic wouldn't exist. So I think the access information certainly helps. Sometimes there is still barriers, like I mentioned, that we have a lack of information available, but that will grow as long as we keep on inputting information to our electronic health record.
So I know you guys are one shop, you're, not that long established, right, a few years. But to me, it seems like a home run in terms of when that happens. But there are so many challenges within the healthcare system. So, in your opinion, if money wasn't an option, what would you see? Would it be like, Kathy Balsam was right across the province and every small community?
Yeah, absolutely. I mean, I think ideally, if money wasn't an option, I think the community pharmacists that already have a really great relationship with the people that are coming to see them all the time would actually have the time to sit down and do this. Just because I work at the clinic doesn't mean I'm the only one that can do this. Any community pharmacist is pretty capable of doing all of this work, but they're totally limited by time and then their other job responsibilities. So we really need to change the way that pharmacy practice looks. We're working on it. I mean, we're getting registered technicians that can take away a lot of the dispensing and the technical aspects of pharmacy, but we've got to change it even more and then provide these pharmacists and community the availability of time to be able to do this. But for now, you can send everybody to me. I do get a little greedy.
All right, well, I think that just wraps it up. If there are any more questions, you guys can talk to Kathy afterwards. I do want to say that if anyone is interested in watching or sharing the recording of today's session, it'll be on the Hair Center website, so you can watch it afterwards. You can share it with friends and family. You can share it on social media so that it has a bit of a broader reach. We'll also be sending out the link for that in the regional, which is the Hair Center newsletter. If you don't get it already, you should, because that will keep you all up to speed on any future Yaffle Connect sessions, which will be holding monthly for now, hopefully even more frequently fall. So you can sign up for that on the Hair Center website. And thank you all for coming out this afternoon, and thank you for watching online, for those of you online. Thanks to Justin for putting it all together today, and Sigma Health Campus Strategic Operations team for their help. As I said, this is our first session today, and we had all sorts of learning to get here, but I think they did a fantastic job, and we really love the setup down here. It's super cozy and great conversation. And thank you so much to Kathy and the team at MTS. You guys are fabulous and patient, and so much information today. And just before we close out, I wanted to ask a quick question. How many people have heard about the MTS clinic before today? Show of hands. And how did you hear about it? Just
via social media.
social media?
Yeah, I think same.
Same?
I heard about it from where I work.
Oh, okay. Right on.
We're looking for this kind of service.
Perfect.
And I heard it from Lumpa.
Oh, yes.